Hi there, my name is Max Hardwick-Morris, and thank you for taking the time to listen to a presentation of our work about iliopsoas tendinitis after hip resurfacing and total hip arthroplasty. Iliopsoas tendinitis is a relatively common complication after total hip and hip resurfacing arthroplasty, and it has multiple causes, including excessive lengthening or offset changes made intraoperatively and large diameter femoral heads. However, it's most frequently attributed to impingement between the iliopsoas and cup due to an exposed anterior surface of the acetabular cup. The incidence of postoperative psoas tendinitis is highly variable in the literature. It typically falls within the 4 to 7% range for total hips and 15 to 18% for hip resurfacings. So we wanted to explore why such a large differential in incidence of psoas tendinitis exists between patients who receive total hips and hip resurfacings using our previously validated computational simulation for detecting iliopsoas impingement. The aims of our study were twofold. One, to validate the simulation in a hip resurfacing cohort, and two, to compare the hip resurfacing impingement results to previously collected total hip results to further understand the mechanism of iliopsoas tendinitis. Our hypotheses were that, one, the symptomatic hip resurfacing cohort would have a significantly greater level of impingement than both the asymptomatic hip resurfacing cohort and the symptomatic total hip cohort. Here is our patient selection flowchart. In short, we retrospectively reviewed an experienced surgeon's database for patients who did and did not have psoas-related groin pain after hip resurfacing surgery. After applying inclusion criteria, we had two cohorts, a symptomatic cohort and an asymptomatic cohort of 12 patients each. At a high level, the simulation process involves segmenting and landmarking postoperative CT scans in ScanIP, registering the implants to their in situ position, and simulating the iliopsoas impingement in standing and supine positions. Looking at the simulation itself, we represented the psoas using 3 different segments that approximate the location and width of where the psoas passes over the acetabular margin and attaches at the lesser trochanter. Within each segment is a green path and a red path. The green path does not include the cup and the red path does. Then the impingement is calculated as the difference between these two paths, which could be thought more intuitively as the stretch of the psoas due to the acetabular cup. We therefore get 3 separate impingement values for both supine and standing pelvic tilts and report the outcomes as mean and maximum impingement, as explained on the slide here. Here is a box and whisker plot showing the main results of the study. On the y-axis is the amount of impingement measured, and on the x-axis are the different parameters, mean and maximum impingement, in both supine and standing positions. We observed significant differences between the symptomatic and asymptomatic hip resurfacing cohorts, with the symptomatic cohort having greater impingement than the asymptomatic cohort. Additionally, when comparing these results to our previous study, we found significant differences between the symptomatic total hip cohort and symptomatic hip resurfacing cohort, with the total hip cohort having greater impingement than the hip resurfacing cohort. So, psoas impingement and tendinitis is understudied, particularly from a standpoint of computational modeling. We have now validated a novel simulation for detecting iliopsoas impingement in total hip and hip resurfacing patients in case-controlled studies by quantifying the impingement observed in patients who have been diagnosed with psoas tendinitis and patients who didn't have psoas tendinitis. The most significant findings of this study were the significant differences in impingement values between symptomatic and asymptomatic cohorts, which showed that the simulation is able to distinguish between hip resurfacing patients who did and did not have psoas tendinitis. Interestingly, there were 2 patients in the symptomatic cohort for whom no impingement was detected, what we might call a false negative. This is indicative of the multi-causal nature of iliopsoas tendinitis. These patients likely experience pain and irritation due to one of the other sources of iliopsoas tendinitis, such as large diameter femoral heads or excessive lengthening or offset. Also interesting was that the simulation showed greater impingement in the total hip arthroplasty patients than the hip resurfacing patients. This was in contradiction to one of our hypotheses, as we thought patients with hip resurfacing implants and psoas tendinitis would have greater impingement due to the general need to implant larger cups in hip resurfacing patients, which would lead to greater cup prominence and greater cup impingement. Thanks very much for listening.